Hi there. Let's look at part 2 of hypersensitivity reactions from chapter 14 of your textbook. We left off looking at cold and warm hemolytic anemias. And so we're going to look just at one example of a specific cold hemolytic anemia, and that's called paroxysmal cold hemoglobinuria. This is an important one to understand and to remember because it is it's classically seen after a patient has had a viral infection, the measles, mumps, chickenpox, infectious mono. And why PCH, paroxysmal cold hemoglobinuria, is an important disease is that it is in fact cause of an intermittent hemolysis, intermittent meaning it comes and goes. And it's a unique disease because it is, the antibody is what we call biphasic. Has two phases in the activation process. The first is the antibody binds at 30 degrees to the red blood cells, but it won't activate complement or that process where the host will destroy a cell that is sensitized with antibody. Won't activate complement until you're at body temperature at 37. So binds in the extremities, kind of those cold places that we talked about before, but it activates complement at 37, biphasic. Because it tends to affect these kinds of viral infections, we see it mostly in children, young adults, and as I said, it's transient. We're not going to see this over a long period of time. It really comes and goes with ease. There's a couple of different kinds. There's a test that we're going to talk about for type 2 hypersensitivity called the DAT, or the direct antiglobulin test. It's also sometimes called the direct Coombs test, named after Dr. Coombs that we talked about earlier today. The DAT we're going to see is a test that detects red cell destruction in a couple of different examples. We see it in hemolytic disease of the newborn, that HDN that we've talked about. We can also see it in transfusion reactions and in autoimmune hemolytic anemias. Not to confound things, but we're also today going to talk about indirect antiglobulin test, or the IAT, or the indirect test. This test really has nothing to do with type 2 hypersensitivity. We're going to talk about it now because these two tests sound so similar, and the test methodology is very similar, but DAT is the test for type 2 hypersensitivity. IAT is a process we use in the blood bank that's going to make sure that the donor blood cells are compatible with the patient's serum. So let's take a look at these two tests. So again, we're going to be testing for type 2 hypersensitivity reactions. And how can we do this? The DAT will be able to detect the presence of red cells that have been sensitized or coated with either antibody, IgG or IgM, or complement components. We're going to talk about the nuances of the antibody sensitization in just a second, but it will detect sensitization of red cells. And as I said, those are the tests that we're going to look at it for a number of different hemolytic issues. The DAT uses what's called a polyspecific antibody as a reagent. This reagent contains a couple of things. It contains anti-IgG, so it's an antibody to an antibody. So it's an anti-human immunoglobulin. We may call it an AHA, anti-human antibody, or an anti-immunoglobulin. We're also going to look for we're also going to have a reagent that's going to have an antibody to complement. And it's going to be C3b and C3d. We don't need that little parentheses. in the reagent. Um, so they're polyspecific. There's a couple of different components in there. If the test is positive with that polyspecific reagent, that screening reagent, we'll do a little bit more testing to rule things out. We'll go over that in just a moment. The DAT test detects both IgG and IgM, but as I alluded to just a second ago, if the we can see what's our anti-human antiglobulin here. It's against IgG, right? And you're like, well, how do I detect IgM sensitization? Both IgG and IgM activate complement and cause complement to fix onto a red blood cell. So because IgG and IgM both cause the action of complement, we can indirectly, in a way, find out that there is IgM sensitization. But if antibody to IgM is present, when we do those confirmatory tests, only the complement test will be positive. So we'll look at that in just a second. And we're going to see, again in just a second, that if there's positive test, a positive DAT, the test is going to be repeated, not with this polyspecific reagent a second time, but with some monospecific reagents, specifically an anti-IgG only and an anti-IgB, anti-complement, C3b and C3d. And as I said, IgM will only be positive with the complement ones. Let's look at how the test works, and I think this will make sense to you. So think about it, but don't look at this and get, overwhelmed. Think about it and draw out for yourself how this test is happening. What are we doing? We're looking to see, does the patient's red blood cells, are they coated with the antibodies that we would typically see in a type 2 hypersensitivity reaction, right? So what do? We're going to draw some red blood cells from the patient. And we're going to add to that. Now, at this point, we don't know because sensitization is not a visible test in the lab. It's not visible in the lab. So at this point, we don't know. Do those red cells have antibodies sensitized on them or not? We don't know. How are we going to find out? We're going to add anti-human antiglobulin, AHA. So we're going to take the red blood cells of the patient and add a little bit of this Coombs reagent, that anti-human antiglobulin. If there's antibody bound to the red blood cells, the anti-human antiglobulin binds to it, binds to the FC region, and what do we get? Do you remember what we call this? We call that lattice formation. And remember, lattice formation is visible to us in the lab. And this is the agglutination that we see as a result of lattice formation. So in this case, spoiler alert, this example where we saw lattice formation happen is a result of there having been sensitized red blood cells, and that we get a positive test. As I said, we initially use a polyspecific reagent that's going to test for both IgG and complement. So if we get a positive test, we're going to do some additional tests. We're going to test it with anti-complement. We're going to test it with anti-IgG exclusively. So this is a monospecific and this is a monospecific reagent. So in this case, how do we interpret this? The polyspecific reagent was positive. So at that point, we know the patient is either sensitized with IgG or IgM or both. But we don't know what it is. We don't know if complement has been fixated or not. So we run the IgG, the anti-IgG, and we got a positive reaction. Again, we got agglutination. So we know the patient's red blood cells, in this case, have been sensitized with IgG. We run anti-C3b, D, I can't read mine, it's too small for me, anti-complement, and we got a negative reaction. So we know complement has not fixated yet, or hasn't been fixated. So we don't, it's not going to be an IgM. That would have turned positive at this point for sure. And we also always run a control at this point. We do know that there's IgG. We know there's IgG present. There's no IgM, there's no complement, and so we have a causative reaction here. We're going to do that and confirm this test. And again, we always run a positive and negative control whenever we use any reagents. They didn't show you a positive control, I think just because they showed you a positive patient. That's the direct antiglobulin test. Super simple. It's testing for sensitization of red blood cells. What would this look like if it was negative? Let's say these red blood cells had not been sensitized with immunoglobulin. We would add the anti-human antiglobulin. I forgot to mention in there, we wash. Anytime you add an antibody, you're always going to wash, right? Just to wash away any excess. And we would not have, because we didn't have this antibody bound and sensitized to the red cells, there would be nothing for this anti-human antiglobulin to bind to. We would have no lattice formation, and we'd end up with a negative test. So, as I said, I'm not trying to confuse things, but let's talk about the indirect antiglobulin test now as well. The only reason we're talking about it again has nothing to do with hypersensitivity. It has to do with the fact that it has a name really similar and uses Coombs reagent to do this. Unlike the direct antiglobulin test, which looked for antibodies sensitized onto red blood cells, directly sensitized, we instead are going to be looking to see not if the patient has antibodies sensitized onto the red cells, but do they have any antibodies in the serum? We do this because we want to see, does the patient have antibody in their serum that when we give them donor red blood cells, it's going to cause a reaction and cause a transfusion reaction. So we're going to test the patient's serum for antibodies to red cells, antigens from the donor. We're going to use this in the case of testing for cross-matching blood. So once the blood bank tech has done all the work, they've determined what the patient's blood type is. Does the patient have any odd antigens? All that stuff. What kinds of blood is going to be compatible with the patient? We're going to do one last check and make sure the patient doesn't have antibody. So it uses patient serum, quote-unquote reagent cells. In this case, we could use the word donor cells, and anti-human immunoglobulin. We're going to incubate the donor red blood cells with patient serum at 37 degrees. We're going to wash to remove any excess immunoglobulin, any extra serum, anything in the serum, and then add that anti-human antibody. Positive test, if there's red cell agglutination, it means that the patient's the donor red blood cells reacted with the antibody in the patient's serum. And that means that's an incompatible test. Patient should not be transfused with those red blood cells. A negative test, we have to do an extra little process called check control. Please remember that. Professor King will, oh no, you're going to have Professor Elamani there. Make sure he'll be impressed if you tell him that you need to always do a check test with IATs. Last note, if the antibody is a cold-acting antibody, an IgM, it's clinically insignificant. Why is it insignificant? Because they react at 30 degrees and blood is not transfused at 30 degrees. It's transfused into a patient. So, it's we worry about warm-acting antibodies or, body temperature antibodies. Let's look at the actual process of the test. So as I said, we're looking for antibody in the patient's serum. So we're using patient serum from the patient. These are reagent or donor red blood cells. And in this case, we're looking to see, does this patient have antibody that matches the little antigens on the outside of the patient's cell surface? Again, spoiler alert, they're showing us a positive reaction. So in this case, the patient has antibody to the antigen. So what we did, we mixed patient serum with donor red blood cells, incubate it, let that sensitization happen. Remember, we can't check this now because sensitization is what? Not visible. So we're going to do a wash step here. We're going to add Coombs reagent, in this case, an Coombs antibodies, and we're going to look to see if we get that cross-linking, that lattice formation. If we did, we know that we had antibodies that attached to this and bound to this. So if this happens and we get that lattice formation, we get a positive agglutination test, just like there. This is an incompatible blood donor, and we need to start over. Let's move on to type 3 hypersensitivity reactions. These are also known as complex-mediated hypersensitivity. And the key components of complex-mediated hypersensitivity are IgG and IgM. And what happens is when small antigens are bound by either IgG or IgM, the small complexes are often not easily cleared by macrophages. They're just the complexes are too small. And what ends up happening is you get some of those antibody antigen bound complexes hanging around in the tissues for a while. They're not getting cleared by macrophages. Kind of irritates the host, causes some inflammation. Again, should be a good thing, but it's not. We're going to talk about complement soon, but complement is activated by IgG and IgM. In both cases, either IgG or IgM will fix complement, and we're going to see a picture of it in a second, that if there's an antibody bound to a cell, then complement can come in and bind in there as well and causes that downstream reaction, a cascade of steps that are ultimately going to lead to the destruction of the cell with the antibody bound to it. Some of the things that happens when complement binds into that complex, vasodilation, the vasculature opens up wide. The vasculature becomes more permeable, so cells are able to move out of into the tissue space more easily. And one of the components of complement called C5a is chemotactic, and we know that is a signal calling for cells to move into the area. And in fact, C5 causes macrophages and neutrophils to move into the affected areas. And what happens when they're there and they see the antibody antigen complexes, they drop all their lysosomal enzymes, causing damage to the cells that are there. There's a lot of tissue damage. You probably heard this in urinalysis, but this is a glomerular basement membrane disease. So we frequently see it in the kidneys. We also can see it in some of the vasculature, the endothelium of the vasculature, the joints, and also the membranes of the lungs, the alveolar membranes. That's just a step. Oh, let's see. Blah, blah, blah. Let's see. Can happen within hours or weeks, depending on prior exposure. Antigen-antibody complexes form quickly, but the effects of the buildup in the tissues can take longer. Some of the examples we're going to see, things like lupus, SLE, systemic lupus erythematosus, the Arthus reaction, which we're going to go over, rheumatoid arthritis, serum sickness, Henoch-Schönlein, Schönlein, purpura, is a vasculitis of the respiratory, that's clearly spelled wrong, respiratory system. Let's look at an illustration of a type 3 hypersensitivity reaction. So remember, we're looking at soluble antigens binding with soluble antibody to form a small complex in the tissue. They precipitate out, bind into the tissue, and they form that kind of irritating complex there. We have antibody, we have antigen, right? And we have these complexes. They're forming a complex here. This is complement, and this is the activation molecule of complement. It's pretty cool looking, right? Does a lot of damage, and we'll go over that separately. But complement can bind to antigen. So once you have this antibody antigen reaction take place, whether this is IgG or IgM, complement can come in here and bind. And it only needs a couple of either one molecule of IgM bound in or two molecules of IgG, because we have to have a couple of places for it to bind. Complement comes in, and again, a number of things happen. They have vasodilation, vasopermeability, chemotaxis from the C5a will cause neutrophils and macrophages to migrate to the affected area. And ultimately, complement, once it's activated, also starts to kill cells that are near there that this may be attached to. So the lysosomal contents get dropped, and we damage all the tissue around this complex. That is a hypersensitivity reaction. Where do we see this? We see a couple of examples. The first is what we call the Arthus reaction. This isn't a really common reaction. It's an important one to remember. It's one of those ones people always ask you about. So this was originally, the Arthus reaction is relatively rare reaction that we see in things that that have a toxoid like a diphtheria or tetanus or measles vaccinations. Originally seen by Dr. Arthus in rabbits. He kept injecting anti-sera into rabbits and seeing damage occur. So it was demonstrated initially in rabbits by Dr. Arthus, and that's how it got its name. But what is an Arthus reaction? Very similar, really, to what we're going to see in just a minute. But it's a reaction that we just discussed. It really is a complex mediator reaction where there's tissue damage after complement fixation. The immune complexes that were deposited in the tissues, it can be deposited in small blood vessels. They complex out into the tissues and cause damage. Complement can activate mast cells. Remember, those are the tissue cells that look an awful lot like basophils but aren't. And they release their mediators, which causes another whole downhill reaction. Mast cells can cause things like thinning of the blood, the heparin. It can cause some vasopermeability, causes increased inflammation, edema. So all sorts of those problems. This is a relatively rapid process that we see in patients when they have boosters. So the patient's been exposed to tetanus and diphtheria, measles before. They get the booster and then they get a reaction. They didn't get a reaction the first time they got it, but at this point, they've already, remember, we got that nice long memory of our immune system. So when you get a booster, sometimes you get that kind of a hypersensitivity reaction to this is showing you a vaccination. You get a hypersensitivity reaction to a vaccination, and it's based on the concept of an Arthus reaction. Along the same lines, anytime a host is immunized with animal serum, we can have a reaction, a type 3 hypersensitivity reaction. We call that a serum sickness reaction. Serum sickness. It's based on the concept of serum sickness comes from the fact that years ago, we used to give kind of a cross immunity, kind of a vaccination, and would give people horse anti-sera to treat different kinds of infections like diphtheria and tetanus. Those are this kind of toxoids. But now we don't do that anymore. But we can still see these animal, reactions, animal venom, animal injection kind of reactions of serum sickness in things like antivenoms that we use for snake bites. We also see it in normal treatments because, for example, and again, oh look at that nice typo, antibodies. Um, Clearly, I was starting to type AB for antibodies and decided to type it out. We use things like monoclonal antibodies that come from mice to treat things like cancer, um, um, and so we can have a very similar kind of a reaction. So we have a couple of cases where we actually do use animal or reptile based anti-sera, and it gets injected into us. Typically, we won't have been exposed to this previously, so the first time we get it, it can take a period of time, kind of, that that slightly delayed 7 to 21 day post-injection, kind of wait for those antibodies to form. The symptoms are generally the things that people complain about when they get when they get vaccines that they have a reaction to: headache, fever, nausea, joint pain, rashes, swollen lymph glands. This is a generally self-limiting hypersensitivity reaction because the reaction is the complexes are going to clear, um, and we're going to have, once the complex is clear, the pain and the inflammation and all that stuff goes away. So what other reactions do we have associated with type 3 hypersensitivity? We have some that are diseases that are involved in the production of antibody to self-antigens. Um, Things like SLE, systemic lupus erythematosus. We see kidney, and we see complexes forming the kidney, the joints. We see its skin damage. Rheumatoid arthritis, as we talked about previously, causes joint pain and joint damage. So that buildup of complexes in tissues or things like your joints causes an incredible amount of pain and damage to the area. Um, so these autoimmune diseases, the end result is a type 3 kind of hypersensitivity. It just happens to be autoimmune based rather than an injection or something like that. Um, Other kinds of type 3 hypersensitivity, things like a bee sting, that makes sense, just like an arthus reaction, um, or a serum sickness reaction. It's being injected with something from um, from a foreign entity. Some drug reactions, things like penicillin, can also cause people, if you know someone like my dad that's allergic to penicillin-based drugs, that causes a type 3 hypersensitivity reaction. And it's important to remember that this can be something that's secondary, a sequela, the great word, sequela, secondary to other kinds of infections. So if you've had, um, let's say, a streptococcal infection, you can actually end up with antibodies produced, and you have a type 3 hypersensitivity reaction secondary to the infection. This is where you get those basement membrane damage that we talked about earlier, of the kidney. So it's a pretty damaging thing to post-streptococcal in the kidney. How do we test for type 3 hypersensitivity testing? We test it with antinuclear antibodies, which will be covered in autoimmunity. We can do some things. We can do some staining of tissue sections to actually look and see if there are deposited immune complexes. Um, we can look for we can use an anti-immunoglobulin, an anti-human antibody, to look for something called rheumatoid factor that, again, we'll talk about in chapter 15, um, specific to rheumatoid arthritis. And we can also test again because this is a complement mediated reaction. Remember that it's, complement is one of the components of this complex that forms. We can actually test for a complement, and it's an indirect test. We can test for complement, and we're going to see that we don't see increased levels of complement. We're actually going to look and see if there's decreased levels of complement. Is the complement being used up in these complex formations? So if you're utilizing a lot of your complement and it's being activated, your serum level is decreased when there's a degree of high activity. So complement is inversely proportional to the level of disease activity in type 3 hypersensitivity reactions. Or it may be, not always, but it may be. We're almost done. Type 4 hypersensitivity reactions are called cell-mediated. So we just had complex-mediated. These are cell-mediated hypersensitivity. These are our delayed hypersensitivity. These are the ones we talked about earlier that are delayed. Why are they delayed? They're cell-mediated, which involves T cells in the cell-mediated immune system. And that is, we know that's a secondary exposure. That's not a secondary exposure, I shouldn't say that. It's an adaptive immune response. We see type 4 hypersensitivity in cases where, for example, the host has intracellular antigens, something intracellular, or some contact antigens. And this is going to involve those type 1 T helper cells that we've talked about a couple of times now, and macrophages as well. Because this is cell-mediated, the hypersensitivity reaction is delayed and generally peaks 48 to 72 hours after a patient has been exposed or a host has been exposed to the antigen. We need to remember that it's transferred via the T cells if it's transferred from patient to patient, host to host. That would be something very specific. We'll talk about that in a few minutes. And clinically, what do we see? This is a lot of skin stuff that we see here. We see contact dermatitis. We see skin allergens. Things that are low molecular weight compounds come in contact with the skin and cause a skin reaction. And we're going to take a look at those in just a few minutes. So what's the process of cell-mediated hypersensitivity? Pretty straightforward. Let's see, we're at the beginning, step 1. Macrophages ingest the antigen and migrate to the lymphoid tissue. So ingest, not inject. Just change that. Ingest. There we go. Might as well do it now so you know. Ingest or take in the antigen and migrate out to the lymphoid tissue. We know this process. They process the antigen, they present the peptide fragment to a naive T helper cell, which then differentiates under the action of cytokines into a T helper 1 cell. The T helper 1 cell then releases additional cytokines to do a couple of things: attract macrophages, to induce some hematopoiesis of the granulocytic monocytic cell line. So they release some cytokines, some growth factors, and they can also induce the they can induce monocytes and macrophages to go into the tissue at the site of the antigen. What happens once this initial process takes place, this initial cell-mediated. Why is it cell-mediated? We started with a T helper cell, right? We need those naive T helper cells that differentiate into T helper 1s to do their job. So cell-mediated. What happens? Macrophages induce some inflammation. Remember, what does that do? Heat, swelling, vasodilation. That brings lots more cells to the area. Cytotoxic T cells also get recruited to the area under the action of chemokines and destroy those targeted cells that contain antigen. What ends up happening from this, and part of the issue of what we see and why we see that skin damage and tissue damage, is that we form what are called granulomas. The tissue that gets damaged by these actions, by the cytotoxic T lymphocytes, by monocytes, macrophages, neutrophils, all releasing their granules, all end up causing tissue damage. Granulomas are small clusters of macrophages that actually form in the tissue specifically, and we can get some additional tissue damage. But so this whole thing kind of cumulatively causes a great deal of damage. Granulomas, very specifically, macrophages are terrific at walling off the phagocytosed organism so that it doesn't spread to the rest of the host. So they form these clusters of protection around the infected site, so that it doesn't go further into the host. It doesn't spread among the host. What are some examples of this? So some things like the causative agent of tuberculosis, Mycobacterium tuberculosis, Mycobacterium leprae, Pneumocystis carneae, which I think that probably, I don't know if you haven't done it yet, but we see this in patients that have HIV. Leishmania, some of the other specific things that can be kind of intracellular, Leishmania species, some of the herpes viruses, specifically herpes simplex virus. Those are all things that are intracellular. So that's the key with hypersensitivity, right? We have things that are intracellular. Some other things that can cause type 4 hypersensitivity reactions are contact antigens. Things that are small, low molecular weight compounds that come in contact with the skin. Off the top of my head, things like poison ivy, and so the reaction of poison ivy, or the reaction, if you know anyone that if they wear inexpensive earrings, they get dermatitis on their ears, or even jewelry, a ring or a bracelet. If they have nickel in them, and they have that very small molecular weight antigen that causes that dermatitis. And then some that specific one that I mentioned earlier and alluded to, that hypersensitivity pneumonitis. It's an allergic reaction of the lungs, which causes inflammation within the lungs after you've inhaled some bacteria or things like fungus. We see that when people are working in the dirt, the stuff gets kicked up, and especially things like fungal spores get inhaled. Patients that are bird breeders can inhale pathogens, and also things like humidifiers which they don't tend to use warm humidifiers as much anymore, because it breeds bacteria, and it was just going into the air, and people inhale it, and they end up with these hypersensitivity reactions. So you'll see, typically they don't recommend, a lot of humidifier anymore, warm humidifiers. So let's look at that, the second one. So this is pretty straightforward. This is the intracellular pathogen one that we just expressed here. This is the intracellular pathogen one, right? Let's look at some of the contact antigens that happen. Again, they're again low molecular weight compounds, contact the skin, and they're a hapten, right? So they sensitize T cells. They sensitize T helper cells. Um, and as I said, some of the examples: poison ivy, poison oak, nickel salts, some materials in cosmetics and hair dye. So if you happen to dye your hair and they tell you to do the patch test first, there's a reason why. You don't know until you've got this all stuck on your head if you're going to have a reaction to it or not. And people that have reactions to like latex, those are very, very small, low molecular weight complexes or compounds that can cause that contact dermatitis. And the picture that you see to the right is exactly what you see when you have a contact dermatitis. Kind of that skin eruption, you end up with some swelling, erythema, the redness, and these papules, the kind of vesicles that are filled with fluid occur. So those are the ideas of how we develop a type 4 hypersensitivity reaction, that delayed hypersensitivity reaction, but how are we going to test for it? There are a couple of different methods that are used. Um, the patch test that we see here is the gold standard for testing for contact dermatitis. Um, just what you would imagine. We're going to, as you can see illustrated here, they literally apply a small amount of the antigen, multiple antigens, to the skin surface, and they wait a couple of days, roughly 24 hours, and they look to see if someone had developed a contact dermatitis. If it's red with papules or tiny blisters, guess what? It's a contact dermatitis. So in this case, they actually mark, they know what each one is. They're a patch. They're all, it's when we don't know what someone is allergic to. And so you can see they mark them off and positive test, positive, positive, positive. This one's negative. So this person has a lot of responses to contact issues. They read it at 2 days, but they can actually go several as early as 6 hours. You can start to see a reading, and as late as say 20, 40, 60, 5 or 6 days, maybe 120 hours or so, you can still have a positive test. The other test that we think of when we think of delayed hypersensitivity is the Mantoux test. And this is the one that anyone that works in healthcare knows, tests for to see if you've been exposed to tuberculosis or not. They inject a small amount of soluble antigen for Mycoplasma tuberculosis. Yeah. Intradermally, it's a small piece of it. They're not actually giving you TB, as you know. And they inject it intradermally, which it means it's just under the skin. So you should understand intradermally. It's just underneath the skin. They wait no less than 48 hours, no more than 72 hours, and check to see if there's what we call an induration. Which is kind of a raised heart area. And they measure that, the size of the induration, and it has to hit a certain threshold in order to be tested as positive. In other parts of the world, patients or people are given the BCG vaccine for TB. In America, we don't do it. So people that frequently are immigrants to the country may have gotten a vaccine outside of this. In which case, if that's you, don't get a TB test. They'll do they'll do an X-ray of your lungs and check it that way. But don't let them do this because your arm is going to swell up like a balloon. you've been exposed to, you've developed antibody to it, so this is going to be really positive. So don't do that. So those are kind of the skin testing that we think of typically for delayed hypersensitivity. Um, and I think that's it. I will talk to you soon. Thanks. Bye.